Welcome to the deep dive. Today we're getting into something really important, using less invasive methods to fix blocked arteries in the legs and pelvis.
That's right. Aortoiliac Occlusive Disease.
Yeah, think of it like the main roads leaving a city. If they get jammed, everything slows down further out. That's kind of what's happening here.
Exactly. And we're drawing heavily from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, specifically the chapters on these endovascular techniques.
Right. And our mission today isn't just to say, hey, arteries get blocked, there are fixes. We want to dig into the details. What are these less invasive options? Who are they really for?
And what are the outcomes, the things to think about long term, beyond just the simple idea of a blockage?
Okay, so let's dive in. Where did all this start? It wasn't always minimally invasive, was it?
Oh, definitely not. You have to look back at pioneers like Dotter and Grunsig. They were really the visionaries behind balloon angioplasty.
So just using a balloon to open things up.
Essentially, yeah. The idea of fixing it from the inside.
Yeah.
Then stent technology evolved, and Palmaz was a huge name there, developing the first balloon extendable stents.
Okay, so those were the early days. Balloons, early stents. What really pushed things towards the endovascular approach we see so much of today?
It was a combination, really. A big leap in technology. For one, imaging got much, much better.
Higher resolution, see things more clearly.
Exactly. Pinpoint the blockages with way more accuracy, and then the devices themselves got better, lower profile systems.
Meaning smaller, easier to insert, less disruptive.
Precisely. And the stents evolved too. You got pre-mounted balloon expandable ones for precision, self-expanding stents that are more flexible for bendy arteries, and then stent grafts.
Stent grafts, like reinforced stents.
Kind of, yeah. A fabric covering over the metal scaffold provides extra support, can seal things off. All these things together just made endovascular treatment safer and more effective.
So much so that, are you saying most people with this condition don't need open surgery now?
For the majority of patients with Aortoiliac Occlusive Disease,
Yeah.
yes. Percutaneous endovascular procedures are usually the first line.
Wow.
And even for the really complex cases, we now have advanced stent grafts, or we use hybrid approaches,
Hybrid meaning.
combining some open surgical techniques, usually smaller ones, with the endovascular tools inside the artery.
That's a massive shift. So let's talk about who gets these treatments. What are the main reasons, the indications?
Okay, so the big one is lifestyle-limiting claudication.
Which is that pain when you walk, right, in the hips, butt,
Yeah.
thighs.
Exactly. Pain or cramping with exercise that goes away when you rest. If it's bad enough to really limit what you can do, that's a clear indication.
Makes sense. What else? More severe stuff.
Yes, definitely for rest pain. Pain even when you're not moving, or tissue loss like ulcers or gangrene. That's critical limb ischemia, a much more serious situation.
So pain at rest or actual wounds on the feet or legs?
Right. Those need urgent attention. Less commonly, things like vasculogenic impotence.
Where the artery narrowing affects erectile function.
Correct. And sometimes, though it's a bit controversial, for atheroembolization blue toe syndrome.
Where little bits break off and go down to the toes.
Yeah, tiny cholesterol bits. Sometimes we might use a stent to kind of trap the source lesion, prevent more emboli. But if the embolization happened because of a recent catheter procedure, that's usually handled differently. Not typically an indication for stenting the source.
Got it. And I think you mentioned using it to help other procedures.
Yes, absolutely. Improving inflow. If someone needs, say, a bypass further down the leg, like a femoral popliteal bypass, but they also have significant blockage higher up in the iliac arteries.
You need to fix the upstream problem first.
Exactly. Otherwise, the downstream bypass won't get enough blood flow. We measure pressure gradients across the iliac lesion.
Pressure gradients.
Yeah, we measure blood pressure above and below the narrowing, a resting systolic difference of more than 10 millimeters of mercury, or a mean gradient over 10 after giving a vasodilator drug.
A drug that widens the vessels.
Right. If we see those pressure drops, it tells us the iliac disease is hemodynamically significant, meaning it's truly restricting flow, and we should probably treat it before or during the lay bypass.
Okay. And what about age? You touched on younger patients earlier.
Yeah, patients under 50, it's an interesting group.
Yeah.
Their long-term results tend not to be quite as durable as older patients, whether you do endovascular or open surgery.
Really? Why is that?
The reasons aren't perfectly clear, maybe more aggressive disease progression. But despite that, endovascular is often still the first choice for them.
Why? If the results aren't as durable.
Mainly recovery time. It's much quicker. And frankly, avoiding the potential side effects of the big open bypass, particularly concerns about erectile dysfunction, is a major factor for younger, active people.
Right, a trade-off between maybe slightly less durability long-term versus faster recovery and fewer immediate risks like that.
Precisely. It's a quality of life consideration, too.
Okay, that clarifies who might benefit. Now, what about the flip side? When would you not go with an endovascular approach? Are there absolute no-goes?
Interestingly, there aren't really any absolute contraindications. No situation where it's completely forbidden.
Huh, okay.
But there are definitely relative contraindications, situations where we have to be much more careful, or where open surgery might be better.
Like what?
Things like juxtarenal aortic occlusion, where the blockage is right up against the kidney arteries, that's tricky territory.
I can imagine.
Or really heavy circumferential calcification, like the artery wall is encased in more than a millimeter-thick ring of calcium.
Like trying to work inside a pipe made of rock.
Pretty much. Makes angioplasty and stenting riskier. Also, a very small aorta, what we call hypoplastic aortic syndrome, or if the blockage is right next to an aneurysm.
That calcification sounds like a recurring theme.
It really is. It impacts device delivery, expansion, risk of rupture. It's a key factor in planning. Also, kidney problems, renal insufficiency.
Because of the contrast dye used for imaging?
Exactly. Risk of contrast-induced nephropathy. It's relative, though. We have ways to minimize contrast, like using CO2 angiography or IVUS guidance, but it's still a concern.
Okay, so anatomy is key. Which brings us to how you actually classify these blockages. I hear TAS A mentioned a lot.
Yes, TAS, the Transatlantic Intersociety Consensus Guidelines. Hugely important. It categorizes lesions based on their location and complexity. It was revised back in 2007, TAS 2.
And it helps guide treatment.
Definitely. Broadly speaking, TAS A and B lesions are simpler, less expensive. Endovascular treatment is generally considered the first-line approach for these.
Can you give an example of a TAS A? Like, what does that look like?
Sure. A TAS A might be just a single short stenosis, say less than 3 centimeters in the common iliac artery or the external iliac artery, or maybe a short narrowing in the aorta below the kidneys.
Okay, pretty straightforward. And TAS B?
A bit more complex. Maybe a total blockage of one common iliac, but short, less than 5 centimeters. Or multiple narrowings in the external iliac totaling, say, 3 to 10 centimeters long, but not involving the common femoral artery down in the groin, still relatively contained.
So A and B are generally endo first. What about C and D?
Right. TAS C, C, and D are the more extensive ones. TAS D, for example, could be a complete blockage of the aorta below the kidneys that extends into both iliacs, or really widespread disease involving the aorta and both iliac systems.
Sounds challenging.
It is. And historically, surgery was the standard recommendation, especially for TAS D. TAS C is sort of in between B and D.
But you said endo is advancing.
Significantly. So now, even for many TAS C and some TAS D lesions, particularly in patients who are high risk for open surgery, endovascular techniques are increasingly used with good results. The lines are definitely blurring.
So TAS C gives that initial map based on the traffic jam. Now, before you jump in, the evaluation must be pretty thorough.
Oh, absolutely critical. It starts with the history. Really digging into that claudication, exactly where does it hurt, when, how far can you walk? And asking about impotence is important too.
And the physical exam.
Listening for bruits, those whooshing sounds over narrowed arteries. Checking pulses carefully, especially the femoral pulses in the groin. We also use non-invasive tests like the ankle brachial index, the ABI.
Comparing arm and ankle pressures.
Right. Gives a good objective measure of flow restriction. Maybe toe pressures too. And sometimes treadmill testing if the resting exam is normal, but symptoms are suggestive. Try to bring up the symptom.
Okay, history, exam, maybe treadmill. Then imaging. You mentioned traditional arteriograms aren't the first step anymore.
Not usually for diagnosis, no. We rely more on non-invasive imaging first. Duplex ultrasound, MRA, and CTA are the main ones.
Pros and cons for each. What's Duplex good for?
Duplex ultrasound is great because it uses no radiation, no contrast dye, so it's good for patients with kidney issues.
Yeah.
It can assess how hemodynamically significant a narrowing is, and it's pretty good for looking at the common femoral artery.
Downsides.
Well, it's not great at visualizing calcification accurately, and it can be technically tricky, operator-dependent, sometimes limited by things like obesity or bowel gas.
Okay. What about MRA? Magnetic resonance.
Magnetic resonance angiography. It gives good pictures of the aortoiliac segment itself, but again, not ideal for seeing calcium. And there's a risk, albeit rare, of nephrogenic systemic fibrosis. in patients with severe kidney dysfunction because of the contrast agent used.
So kidneys are a factor there too, which leaves CTA.
Computed tomographic angiography.
Yeah.
CTA is really the workhorse for planning these days. It shows the location, the length of the blockage, and critically, the amount and pattern of calcification.
Which we know is important for deciding on technique.
Hugely important. That 1 millimeter circumferential calcium, CTA shows that well. The downsides are radiation exposure and the need for iodinated contrast dye, which again is a concern with kidney problems.
You keep mentioning the common femoral artery, the one in the groin. Why is looking at that specific spot so crucial?
Because significant disease there, say more than 50% narrowing, often changes the whole plan. It usually pushes you towards a hybrid approach.
The combined open and endo procedure.
Right. You'd typically do an open surgical clean-out of the common femoral artery and endarterectomy, and then combine that with stenting the iliac arteries from above. If the CFA is okay, you might be able to do a totally endovascular procedure.
And what if the problem isn't just in the iliacs but goes right up to the bifurcation where the aorta splits?
Yeah, aortic bifurcation lesions, they often look different, kind of bulging outwards, exophytic, and often quite calcified.
Tricky to treat.
Can be. The main goal there is restoring good flow, good hemodynamics. You might even accept a slightly imperfect picture on the angiogram to avoid pushing too hard and causing a rupture. And because they bulge out and can be crumbly, primary stenting or using a stent graft right away is often preferred.
To sort of trap any potential debris.
Exactly, prevent it from showering down the legs.
Okay, that makes sense. So we've covered the background, who needs it, the warnings, the evaluation. Now let's get into the actual procedure, the techniques. What happens first?
Well, before the procedure even starts, pre-treatment is key. Patients are usually put on antiplatelet therapy, like aspirin, maybe clopidogrel, and definitely a statin.
Standard stuff for artery disease.
Right. And interestingly, some big recent trials, Compass and Voyager, showed that adding low-dose rivaroxaban, a blood thinner, to aspirin might actually be better than aspirin alone for preventing future limb problems and cardiovascular events in many of these patients.
So the medical management is evolving too. Okay, patient is prepped. How do you decide where to stick the needle to get access?
It depends on where the blockage is. For the common iliac artery, usually we go in from the groin on the same side, ipsilateral retrograde access. Go up against the flow. Unless that common iliac is totally blocked right at the start. Then maybe we put a catheter in from the other groin first, the contralateral side, just to get pictures and understand the situation fully before trying to cross the blockage. It also gives you options for protecting the other side.
And for the external iliac artery, further down.
For the EIA, we often prefer going in from the opposite side, contralateral. Give you a better angle to work downwards, especially if you need to treat near the common femoral artery. But regardless, a full diagnostic angiogram is essential first.
See the whole picture, aorta near the kidneys, the iliac branches, femoral artery, runoff down the leg.
Everything. You need the full map.
Okay, you've got access. How do you actually get through the blockage itself?
We use guide wires and catheters. Start with maybe an angled catheter and a soft-tipped wire. Try to gently navigate through. Hydrophilic wires, which are very slippery when wet, are really helpful for tough crossings.
Once you think you're through.
You advance the catheter over the wire, then pull the wire out and see if you get good blood return through the catheter. Confirms you're in the true lumen, the main channel of the artery.
And how do you know if a narrowing you see needs fixing? Is just seeing it enough?
Not always. That's where those pressure measurements come in again, measuring the pressure drop across the lesion.
The 10 millimeter Hg difference.
Right. Either at rest or after giving a vasodilator drug like nitroglycerin or papaverine. If you get that significant pressure drop, it confirms the narrowing is restricting flow and warrants treatment. Pressure wire measurements are often more reliable than just looking at the angiogram image.
Okay. What about the really tough ones, the chronic total occlusions, CTOs, completely blocked arteries?
Yeah, those are the biggest challenge. Try to cross a totally blocked common iliac from the same side. Often leads the wire into the wall of the artery, the subintimal space.
And it's hard to get back into the main channel.
Very hard sometimes.
Yeah.
In those cases, coming from the opposite groin, antegrade, down towards the blockage can work better, especially if there's a little nub, a stump, of the artery still open where it comes off the aorta.
Use a special catheter to aim for that stump.
Exactly. Like a curved catheter, try to engage the stump, then use a hydrophilic wire to cross.
And if that doesn't work, if it's blocked flush with the aorta?
Then contralateral access often fails. The next options might be going in from the arm, a brachial approach.
From the arm. Why?
Gives you more pushability, better support to get through the blockage, maybe less risk of tearing the aorta. But it's not always feasible if the patient has blockages in their arm arteries. Or sometimes, believe it or not, going back to the original side, ipsilateral retrograde, but maybe with specialized tools.
Like those re-entry devices.
Exactly. We have wires designed to vibrate or rotate to help stay in the true lumen. And then re-entry catheters, like the Outback or Pioneer devices.
How do they work?
They allow you to intentionally travel in that subintimal space alongside the blockage, and then further down, use a tiny retractable needle guided either by fluoroscopy or IVUS intravascular ultrasound.
Ultrasound from inside the artery.
Right, to guide the needle puncture back into the true lumen beyond the blockage. Quite sophisticated.
Sounds like it. Okay, what about blockages right at the bifurcation, where the aorta splits? Special techniques there.
Yeah, the classic technique is kissing balloons, inflating balloons simultaneously in both common iliac origins.
Even if only one side is badly blocked.
Traditionally, yes. The idea was to prevent plaque shifting over and blocking the good side or causing a tear. Although some recent data suggests maybe you don't always need to protect the other side for simple one-sided lesions.
Interesting. And for tougher calcified bifurcation lesions?
Then often kissing stents, placing stents simultaneously, or even reconstructing the bifurcation using stents that extend up into the aorta a little. There was some concern that could create a spot for clots, but it's often necessary.
And you mentioned stent grafts becoming more popular here too.
Yes, especially for the more complex TAS A, C and D bifurcation disease. Using covered stents, either built on-site with aortic cuffs and iliac limbs, or using a dedicated unibody bifurcated stent graft.
What's the advantage of the unibody graft?
Besides reconstructing the bifurcation smoothly, it preserves access to the other side if you need to go back in later.
Makes sense. Let's loop back to that common femoral artery issue. If you do need that hybrid approach, how does that work logistically?
Okay, so the surgeon exposes the common femoral artery. Then, before doing the clean-out, the endarterectomy, we often stick a needle directly into the exposed artery to place our wire up across the iliac blockage.
Get the wire in place first.
Right. Then the surgeon does the endarterectomy and patches the artery closed. But the wire is left coming out through the patch. Then we can insert our sheath over that wire and deploy the iliac stent, maybe landing it right at the top of the surgical repair.
Clever sequencing.
If getting the wire up from the groin doesn't work initially, maybe use the contralateral or brachial approach first, get the wire down, and then retrieve it out through the arteriotomy during the open part. Lots of options.
Okay, wires across, maybe the CFA is fixed. Now, deploying the actual stent, sizing must be crucial.
Absolutely critical. You generally oversize the stent slightly compared to the normal artery diameter nearby, maybe 5 to 10% bigger.
To make sure it anchors well.
Right. Get good apposition against the wall. Unless it's really heavily calcified, then you might be more cautious, maybe size it 1:1 to avoid rupture. Length is important too. Need to cover the whole diseased segment.
What about just ballooning without a stent? Sizing there.
With balloon angioplasty alone, it's often safer to start slightly undersized and then go bigger if needed. Can't do that easily with balloon expandable stents, though once it's deployed, it's deployed.
And how do you know you got a good result?
Angiography helps, looking for less than 20% residual narrowing. But the pressure gradient measurement is often more telling. You want that gradient across the treated area to be less than 10 mm Hg afterwards.
Pressure doesn't lie.
Pretty much.
Yeah.
And IVUS, that internal ultrasound, is also really useful after stenting to check if the stent is fully expanded and sitting snugly against the artery wall.
Makes sense. Now, the stents themselves. Balloon expandable, self-expanding, bare metal, covered. How do you choose?
Lots of choices. Depends on the situation. Balloon expandable stents are very precise to place, show up well on X-ray, and have strong outward force. Good for calcified lesions, but they're stiffer.
And self-expanding.
More flexible. Better for bendy, tortuous arteries or if you're coming across on the other side. They just spring open once released from the delivery system.
So maybe balloon expandable for short, tight, calcified spots at the bifurcation.
Often, yes. And self-expanding for longer lesions or navigating curves.
And the covered ones, the stent grafts.
Used for specific things like aneurysms or if there's a rupture or perforation during the procedure. But increasingly, as we'll discuss, they're used for complex occlusive disease too, especially TAS A, CD. They come in both balloon expandable and self-expanding versions.
And what if you have to stent across the origin of the hypogastric artery, that pelvic branch?
If you need to preserve flow into that artery, you typically use a bare metal stent, not a covered one, across its origin to keep it open.
Okay, that's a whirlwind tour of the techniques.
Yeah.
Now, the million-dollar question, how well does all this stuff work? Let's talk results.
Right, outcomes. Let's start basic. Plain old balloon angioplasty versus only stenting if the balloon result isn't good enough, selective stenting.
How do they compare?
Both can work initially. But angioplasty alone has higher risks of complications, like dissection tearing the artery lining or recoil, where it narrows down again quickly, especially in total blockages.
So stenting seems safer.
Generally less risk of those acute problems. The Dutch iliac stent trial looked at this, found no major difference in long-term patency between primary stenting and selective stenting.
Patency meaning how long it stays open.
Right. But selective stenting was cheaper initially. The catch was a lot of the patients who only got ballooned ended up needing a stent later anyway. High crossover rate.
So maybe just stenting from the start makes sense sometimes. Primary versus selective.
Well, meta-analyses combining multiple studies suggest primary stenting does give better initial technical success and seems to improve primary patency, especially long-term.
For both claudication and the more severe CLI.
Yes. Interestingly, once you get a good initial result, long-term patency isn't that different between treating a stenosis versus a total occlusion. Getting it open successfully is the key first step.
Okay, now link this back to the TAS A classification. Does complexity predict outcome? TAS A and B versus C and D.
It definitely does. For TAS A and B, the simply lesions, endovascular treatment, especially with stenting, gives really good long-term patency rates, comparable to open surgical bypass in some studies.
That's impressive.
It is. Though things like high blood pressure, high cholesterol, kidney disease, they increase the risk of failure. And getting a good hemodynamic result initially predicts better long-term success. Stent or no stent didn't seem to matter as much in those simpler AB lesions.
But for TAS C and D, the complex ones.
Historically, endovascular treatment with just bare metal stents didn't hold up as well as surgery for C and D lesions.
Lower patency rates.
But that's changing.
Yes, newer studies and meta-analyses are showing better endo results even in C and D, especially as techniques improve, and importantly, with the increased use of stent grafts.
You mentioned another classification, GLN-LES. How does that relate to outcomes? Right, the Global Limb and Anatomic Staging System. It's specifically for chronic limb-threatening ischemia, the severe end of the spectrum. It stages the inflow disease complexity and includes femoral disease assessment.
And guides treatment.
The idea is, yes, like class stage 1A might be endo first, while average risk class 2 patients might lean towards surgery. It's another tool to stratify risk and likely outcomes.
What about that common femoral artery disease again? If you treat both the iliac's endo and the CFA, open the hybrid approach, how does that do?
That hybrid approach shows pretty good long-term patency. And some studies suggest stent grafts in the iliacs might do better than bare metal stents when combined with CFA and darterectomy.
Better than bypass.
Some comparisons to aorta bifemoral bypass show the hybrid approach has lower early mortality, maybe similar one-year patency, though maybe higher one-year mortality. In some analyses, it's complex. But meta-analyses do show hybrid improves patency over just iliac endo alone if there's significant CFA disease.
So fixing the CFA is key if it's diseased.
Absolutely crucial for durable results in that scenario.
Are there other things that predict failure besides TAS class or CFA disease?
Yeah, several factors pop up.
Yeah.
Involvement of the external iliac artery, especially severe disease there, seems to decrease durability compared to just common iliac disease.
Any other patient factors?
Things like female gender, having kidney problems, presenting with CLI instead of just claudication, and non-Caucasian race have sometimes been associated with worse outcomes after iliac stenting. Though not all studies agree, particularly on the EIA versus CIA difference.
Okay, let's focus on stent grafts again. You said they're used more for complex cases. Do they actually perform better?
The evidence is building that they often do, especially in more severe disease, TAS CD. Studies like Rutherford's showed better patency with stent grafts versus bare metal stents in complex cases. Even better is combined with CFA and darterectomy.
Any big trials?
The COBEST trial was important. It directly compared covered versus bare metal stents for TAS E, B, C, and D lesions. It found significantly better 5-year primary patency with the covered stent grafts. Especially for the TAS C, C, and D lesions. That's where the benefit was most pronounced. Predictors of patency in that trial were using a stent graft and the initial severity, the Rutherford class.
So stent grafts seem beneficial for complex disease. Any downsides or specific failure predictors for them?
Again, that common femoral artery disease really stands out. If you use a stent graft in the iliac but leave significant disease untreated in the CFA, the long-term patency is much worse. Combining iliac stent grafting with CFA endarterectomy gives much better results when both are diseased.
It keeps coming back to treating the whole picture. Okay, we've talked success rates. What about the risks, complications?
Right. Nothing is risk-free. While endovascular is generally safer upfront than open bypass,
Which you said can have up to 30% complication rate.
yeah, major open surgery has higher perioperative risks and much longer recovery. But endovascular procedures still have potential complications, maybe 1–3% overall rate for access site issues.
Like at the groin puncture site.
Exactly. Hematomas, bleeding under the skin. Pseudoaneurysms where the hole in the artery doesn't seal properly. Careful puncture technique, right in the common femoral artery, not too high or low, helps prevent these. Using closure devices can also help seal the hole.
What about blocking the femoral artery itself?
It can happen, especially if you disrupt plaque on the back wall when putting the needle in. Suddenly the leg goes white, loses pulses. That's an emergency needing surgery right away.
Scary. Any other major risks? Further away from the site?
Remote arterial rupture is rare, less than 1%, but very serious.
Where does that usually happen?
More common when ballooning or stenting, small, heavily calcified external iliac arteries. They're just more fragile.
How would you know?
If the patient's awake, they might get sudden severe flank or back pain. If it happens, you stop dilating immediately. Treatment is usually placing covered stent grafts to seal the rupture. If they're unstable, maybe use a balloon temporarily to stop the bleeding while you get the stent graft ready.
Okay. What else can go wrong inside the artery?
Arterial dissection, the tear in the lining, often happens from overdilating a calcified spot, usually treated by extending the stented area to tack the flap down.
And bits breaking off. Embolization.
Less common if you're not overly aggressive with predilation before stenting the main lesion. But it can happen. Need to check pulses and skin carefully before and after the procedure.
So procedure's done, hopefully successfully. What comes next? Post-op care?
It's definitely not one and done. Ongoing care is vital. Managing those risk factors, stop smoking, control blood pressure, cholesterol, diabetes. Absolutely. Continue antiplatelet therapy, continue the statin, and like we mentioned, maybe add low-dose rivaroxaban for secondary prevention if it's appropriate for that patient.
And follow-up visits.
Essential. Typically see them back at 1 month, 6 months, then yearly. Check their symptoms, examine their pulses, and do hemodynamic testing, usually in ABI.
How do you define if things have actually improved significantly during follow-up?
We look for both subjective and objective improvement. Symptomatically, they need to move up at least one clinical category, like severe claudication to mild, or 2 categories if they started with tissue loss.
And objectively?
That clinical improvement needs to be backed up by hemodynamic proof. An increase in the ABI of more than 0.10 is the usual standard. Or improved toe pressures if ABI isn't reliable.
And how do you check if the stent itself is still open? Patency.
That requires imaging. Follow-up duplex ultrasound is common. We look for normal flow patterns, biphasic or triphasic, in the femoral artery. Inside the stent, while criteria aren't perfectly standardized, a doubling of the peak blood flow velocity compared to the segment just before it, especially with a drop in ABI, strongly suggests restenosis significant re-narrowing, usually defined as 50%.
Got it. This has been incredibly detailed. I know the Rutherford chapter has an algorithm figure that sort of pulls this all together.
Yes, figure 111.12. It's a flowchart, basically. It walks you through the decision-making. Starts with symptoms, then physical exam findings like pulses, then imaging results, CTA, duplex findings.
Incorporates TAS A.
Yes, considers the TAS A classification, and crucially, whether there's significant common femoral artery disease. Based on all that input, it guides you towards the most likely appropriate treatment. Endovascular alone, a hybrid approach, or open bypass surgery.
So it formalizes the thought process we've been discussing.
Exactly. It's a practical tool to apply all these different factors to an individual patient.
Okay, let's try and wrap this up. What's the main message, the key takeaway from this deep dive on endovascular treatment for aortoiliac disease?
I think the main takeaway is that endovascular therapy is now really a cornerstone for treating this condition. It's not fringe anymore, it's mainstream, and it's constantly evolving.
With lots of different tools and techniques.
Full toolbox.
Yeah.
But it's not one size fits all. The choice depends heavily on the patient, the specific details of their blockage, task class, glass stage, how much calcium there is, and very importantly, whether that common femoral artery is also involved.
And success isn't just about opening it up initially.
Not at all. You have to weigh the short-term success against long-term durability, the patency, and the potential complications. And the rise of hybrid procedures really highlights that sometimes you need to combine approaches to address the whole problem effectively.
It's truly a complex field with amazing progress. This has been fantastic, really illuminating. It leaves me, and hopefully you listening, with a final thought to chew on. With all these advanced endovascular tools and sophisticated classification systems like TAS and glass, how might research in the future refine even further how we choose between open surgery and endovascular repair? How can we get better at predicting long-term success for specific patient profiles, perfectly balancing that desire for less invasive treatment with the need for durable, lasting results? It's a critical balance.
A very important question for the future.
Indeed. Thanks for joining us on this deep dive.